In the previous section, we have discussed on oxygen hemoglobin dissociation curve. In the current section, we are going to discuss on pulse oximetry and the dyshemoglobins. Dyshemoglobin, in the sense, the most important dyshemoglobins for your exam are two things, that is methemoglobin, and you have something called carboxyhemoglobin. These are two things that are very important for your exams. But to be honest, there is one more thing that can also be discussed along with this particular topic, that is called cyanide poisoning. That also we are going to discuss. So first, in this very basic and beginning thing, we'll be discussing on the pulse oximetry in the first place. So let us see the pulse oximetry. So what are the arrangement of apparatus and what the pulse oximeter is based on, and all these things is what we are going to discuss. Pulse oximeter typically works on two principles. One is called the Beer's law, and second one is what we call it as the Lambert's law. So simply you can write this as something called a Beer-Lambert principle or Beer-Lambert's law. So if you ask me what do you mean by this Beer-Lambert's law, then the pictures which I have shown itself makes you a clear understanding. Beer's law states that the amount of absorption of a light passing through a solution, the amount of light absorbed on the other end of the solution after passing through a solution depends on the concentration. So for example, if you have a very low concentration mentioned by the blood movement here, you can see a very low concentration. If there is a very low concentration, there will be very low absorption of the light by the solution, and the amount of light reaching the other end of the solution will be very high because the absorption is very less. Similarly, if you see a very high concentrated solution, you can clearly see that the absorption will be very high and the amount of light reaching on the other side will be very less. So this is the principle. This is what we call Beer's law. At the same time, you have something called the Lambert's law. What Lambert's law means is the amount of light that is reaching the other end of the solution again depends on the path length. So Lambert's law, Beer's law is based on concentration, and Lambert's law is going to be based on path length. Or you can tell amount of light that will be absorbed by a solution is again dependent on the path length. Suppose if the path length is very less, for example, in the solution, if you can see this is the path length, if the path length is very less, similarly there will be less absorption. If you have a more path length, here you can see the path length is more, in this condition there will be more absorption, so which means the light reaching on the other side of the solution will be less. So this is what we call Beer and Lambert's law. So this is what we are going to use in the pulse oximetry typically in the first place. This law has to be very thorough. This is what we refer to as Beer-Lambert's law. So next you have to know about the pulse oximeter apparatus. So how the pulse oximeter apparatus, you have initially, the first one is you have two emitters. This is what we call the emitters. The moment you call emitters, you're going to name it as LEDs, that is light emitting diode. So these are the LEDs that are going to emit two different wavelengths. The standard pulse oximeter emits two different wavelengths. If you ask me what are the wavelengths that they are going to emit, first one is in the red spectrum, that is 660 nanometer, and second one is the infrared spectrum in the 940 nanometer. You can see 940 nanometer mark, and second one you can see in the 650 nanometer mark. So these are the two things that are emitted. So these are the LEDs that are emitting these two wavelengths. Then on the other side, you have to have an absorbing substance, agent, so which is typically we call it as a photodiode. So this is the photodiode on the other end of the pulse oximeter. It's going to absorb the amount of light after passing through that particular solution in the finger. The solution is the blood, obviously. So that is going to be absorbed. And finally, in the detector, you are going to see the amount of red light that is absorbed, and you can tell the ratio of the amount of infrared light that is absorbed. This ratio will be compared, and it's going to tell the saturation. Let us see how it's going to tell the saturation by seeing this. So, and third thing, you should have a microprocessor also. So this is the microprocessor, a chip that is going to analyze amount of red light as well as the infrared light that is reaching the other end after getting absorbed, and it's going to find out the ratios. Why these ratios are very important? Let us see. If you see here, if you take the red light, you can see here the red light, you can see the absorption spectrum. This is the absorption spectrums, though this one is the absorption spectrum at different wavelengths. You can see the wavelengths over here. So at different wavelengths, you can see the absorption spectrum of a deoxyhemoglobin. So this is the deoxyhemoglobin which I have drawn here. And you can see the absorption spectrum which I am going to draw in green. This is the absorption spectrum of a oxyhemoglobin at the same different wavelengths. So we plot a graph, this is what you're going to get. And one important definition is that the point at which both the absorption spectrums coincide with each other, which means the absorption spectrum, for example, typically roughly in this case it's around 800 nanometer. At this point, the absorption spectrum of both red light as well as the infrared light is going to coincide, and this is what we refer to as something called an isobestic point. So now, what is the advantages? For example, if you are going to emit a red light. So in this condition, you can see at the red end of the spectrum, the absorption spectrum of deoxyhemoglobin is maximum. Typically, the deoxyhemoglobin is the one that absorbs maximum light at the red spectrum. And similarly, if you ask me at the infrared spectrum, you can see the oxyhemoglobin is the one that is going to absorb maximum light. So which means at 940 nanometer, your oxyhemoglobin is going to absorb the maximum light. At the same time, your at a 660 nanometer, your deoxyhemoglobin is the one that is going to absorb the maximum light. You can see the absorption of the oxyhemoglobin at 660 is very, very less. The deoxyhemoglobin is the one that's going to absorb maximum light at 660 nanometer, and your oxyhemoglobin is the one that is going to absorb maximum light at 940 nanometer. So when you are emitting 660 and 940, literally 660 you are emitting for deoxyhemoglobin, finding out the deoxyhemoglobin, and 940 nanometer you are going to emit for finding out the oxyhemoglobin. Typically this is how a pulse oximeter works. So when the ratio is there, for example, when you are going to have when you are going to do these two different comparisons, this is how you are going to find out this thing. I'm going to discuss it by a separate image, how you are going to find out. So there are two types of pulse oximeter. Typically what we are discussing till now and what is most commonly used is the absorbance type pulse oximeter, where typically it works by Beer-Lambert's law, where you have an LED emitting the light which will be captured on the other side by a photodiode. As simple as that. And second one, currently we have new types of pulse oximeter. That is the basis of using a forehead pulse oximeter and all. Still forehead pulse oximeter is still available. So second type of pulse oximeter, we are going to call it as something called a reflectance type pulse oximeter. So if you ask me what do you mean by reflectance type pulse oximeter, the light emitted will be reflected back. Some amount of light will be reflected. It's not like everything, because finger is something opaque. The living tissues are something little bit opaque and it reflects the light also. It's not fully translucent. So this reflected light you can measure, and that can also be used as a calculation purpose, and that can also be used for telling the amount of light that will be absorbed in the first place. So if you ask me what are the advantages and disadvantages of the pulse oximeter. So the major advantage of the pulse oximeter is the rapidity. And before that, I didn't tell you on how this scenario works really in the first place. So how the ratios of different infrared and red light is going to work in the first place. So you can see this image here, so which can clearly tell you. For example, if there is only oxyhemoglobin, the saturation, which means the saturation is 100%, theoretical example, there is only oxyhemoglobin in this example, in this patient. So what really happens is when you tell, this is the curve for oxyhemoglobin, isn't it? Which means the deoxyhemoglobin is 0%. You can zoom this image. The deoxyhemoglobin is 0%, the oxyhemoglobin is 100%. So the entire curve is going to follow the oxyhemoglobin pathway. So which means in this condition, if you see the ratio of the red light that is getting absorbed to the ratio of the infrared light getting absorbed, you are going to get this particular ratio. So if this ratio, if you find, so this is the red light that is absorbed and this is the infrared light that is absorbed. So if you are going to get this ratio, this is going to tell you that it is 100% saturation. Similarly, if you don't have deoxyhemoglobin at all, oxyhemoglobin at all, which means the saturation is 0%, which means there is 0% oxyhemoglobin and full 100% is going to be deoxyhemoglobin only. And your curve is going to follow the exact curve of a deoxyhemoglobin only, because there is only deoxyhemoglobin in the blood. This is an hypothetical assumption. Obviously, it's a dead patient, but like this hypothetical example, where you can see this is the amount of light that is absorbed by, the red spectrum, and you can see this is the amount of light that is absorbed in the infrared spectrum. So you can see the ratio here. if the pulse oximeter, that photodiode and the microprocessor is going to detect this thing, this particular height, so now you can tell the saturation is 0%. So if this is the height, the saturation is going to be 100%. Now finally, if the saturation is, if this is the height, the saturation is going to be 100%. So now supposedly, if this is going to be the ratio, for example, if the saturation is 50%, which means there is 50% of oxyhemoglobin and 50% of deoxyhemoglobin. So the absorption spectrum will not be behaving like an oxyhemoglobin, or it's not going to behave like a deoxyhemoglobin curve also. It's going to be somewhere in between. So it's going to be somewhat as an average curve. So it's going to follow something like this. So it's an average of the two curves. That's how it's going to behave. So now you can take the how much is absorbed by the oxyhemoglobin, how much is absorbed by the deoxyhemoglobin, this thing at the red spectrum, and how much is absorbed in the infrared spectrum. Now you will get a different ratio, and if the pulse oximeter detects this particular ratio, and all these things are fed into the system, and once they detect this ratio, you're going to get, the pulse oximeter reading is going to show 50%, which means at every single percentage, 1, 2, 3, 4, at all the percentages, the ratios will be pre-fed into the pulse oximeter microprocessor in the chip. So which means the moment it detects a particular ratio of the red to the infrared absorption spectrum, it's going to tell that this is the saturation in the patient. So this is a very simple process, very elegant thing that a pulse oximeter is done. Initially, like you have a pulse oximeter is one of the superb things that the mankind has ever discussed. Like in the 1970s, the pulse oximeters tend to be so huge, like they used to carry it in a suitcase, like the finger probe itself will be this much big and the machine size itself will be like a big suitcase. But right now we have a pulse oximeter which is handheld itself, which is finger held in fact, rather than a handheld pulse oximeter. It's so small, so that because the advancements in the technology. So this is a very simple process that the pulse oximeter uses. It's completely based on the Beer-Lambert's law. At the same time, it does a lot of corrections also, because our human tissue is not exactly going to follow the Beer-Lambert's law, even though it's true, but a solution is different, a dynamic human thing is different. They might have an edema, they might have a lot of other things going on. The flow rate may be faster, slower. Apart from that, the reflectance may differ depending on the substances present in the blood, protein content. So many things are going to affect the, not only the hemoglobin part. A lot of things are going to affect the absorption spectrum also. That's why the pulse oximeter also is pre-fed with some little bit of corrections as well. But anyways, going into details is beyond the scope of what we're going to discuss in the current video. So I'm going to stop it here. So this is the ratio of the absorption of the red light to the infrared light. This is the key. So this is what is going to give the saturation in the pulse oximeter probe. So after knowing this, we can tell what are the advantages of the pulse oximeter and what are the disadvantages of a pulse oximeter. What are the advantages of a pulse oximeter and what are the disadvantages of a pulse oximeter? So if you ask me about the advantage of the pulse oximeter, first of all, it's rapid, completely non-invasive. You don't need an ABG for that. At the same time, it allows you the continuous monitoring. So it allows you something called a continuous monitoring. But what are the disadvantages? Number one, it cannot tell you hyperoxemia. What do you mean by hyperoxemia? Whether the patient is over-oxygenated or not. So over-oxygenated is dependent on PaO2. So that's the second thing. It cannot measure the PaO2. It cannot detect hyperoxemia. It cannot detect the PaO2 also. It cannot detect the PaO2. Obviously for PaO2, I told you need ABG. You cannot detect by pulse oximeter. So which means if you take the oxygen hemoglobin dissociation curve, so let me draw it again for you, the oxygen hemoglobin dissociation curve, the curve is going to follow something like this, which means it reaches a saturation point, maximum saturation. For example, if the PaO2 is 95 to 100 millimeters of mercury, at this point the saturation is going to be 100%. Beyond which, how much ever increase the PaO2, it doesn't matter. For example, if the PaO2 is 300 millimeters of mercury, suppose. Yes, you can do it by over-oxygenating the patient. So hyperbaric oxygenol can increase the PaO2 to even 1000 also. So if you are going to increase the PaO2 to 300, but still the curve is going to maintain the same because it has reached already the full saturation point, that is 100%. Hemoglobin cannot carry any more oxygen, but still the patient's dissolved oxygen is very high, which can still result in hyperoxemia induced damage to the patient, because oxygen is even though at limited levels it's fine, but too much of oxygen is also very bad because it's going to oxidize a lot of substance in the body, is going to generate free radicals as well. So that's why hyperoxemia related injuries and all cannot be determined, because it cannot measure the PaO2, not possible. For you need ABG for that. And the third thing, disadvantage of a pulse oximeter is it cannot measure ventilation. It cannot measure the ventilation as well. So why it cannot measure, which means indirectly it means it doesn't measure PaCO2. That's what it means. It doesn't measure the PaCO2, which means you don't know about the ventilatory state also. I've seen a lot of patients with very poor ventilation, respiratory rate of only 8, PaCO2 in the range of 60, 70, but still the saturation will be, maintained okay, maybe 90, 92% in many of the COPD patients. That's true. So you can't measure the ventilation with the pulse oximeter, definitely, for sure. So these are some of the disadvantages. What are the things that are shown by the pulse oximeter? In the display, what are the things you're going to see? So there are many things you're going to see in the display. Classically, you're going to display the SpO2. Remember, don't tell SaO2, because whenever the saturation of the hemoglobin is measured with the help of pulse oximeter, you have to call it as SpO2 and not SaO2. Very important. So only if you do by ABG, you call it SaO2. So it's a SpO2, it can measure, yes. At the same time, second thing, the pulse oximeter also displays the pulse waveform. Pulse waveform, or less, otherwise we call it as amplitude. This also is measured. For example, if you ask me, this pulse amplitude or the pulse waveform that is shown by the pulse oximeter is based on volume. Based on volume and not pressure. So which means don't take this as an equivalent of the pulse pressure. Pulse pressure can be done only by the blood pressure measurement, not by pulse oximeter. Pulse oximeter can tell the amplitude, pulse volume it can tell, but it cannot tell the exact pulse pressure. This is a very important question as well in your exam. So you need a BP apparatus, maybe intraarterial in the ICU, or maybe a routine BP itself will suffice in the OPD or in a routine IP setting. So you need a BP apparatus to find out the pulse pressure. This can measure only the volume. That's going to tell. You can see in the pulse oximeter, a lot of people would have seen in the pulse oximeter something like this will come. The pulse volume amplitude also will come along with the pulse oximeter display. So this is a very common thing that most of the pulse oximeters tends to do it. And there are a lot of questions do come. This SpO2 means arterial oxygen tension, that is arterial saturation or venous hemoglobin saturation. Because venous hemoglobin saturation is completely different, because in the curve if you take, so this is a normal arterial PaO2, but this is the normal SpO2 for that matters. But if we take the venous is very low, because you have donated a lot of oxygen to the cells while passing through the capillary. So the venous oxygen content as well as the partial pressure of oxygen in the veins will be definitely low. Which means if you tell PVO2, that is partial pressure of venous oxygen, it's approximately, normally it's around 40 millimeters of mercury. I can write here, that's approximately 40 millimeters of mercury. This is the partial pressure of venous oxygen. But at that rate, if you see the oxygen saturation, it's approximately 65 to 75%. That is what we refer to as something called SVO2, otherwise called as saturation of hemoglobin saturation of venous oxygen. It's a venous blood, so that's why you call it SVO2. Many books do also give this as a mixed venous oxygen saturation. This is also referred to as something called mixed venous oxygen saturation, because arteries, wherever you measure the brachial, radial, everywhere is going to be the same. You're going to have the same amount of arterial oxygen saturation, but if the veins are not like that, because the extraction by different organs is different. For example, heart extracts a lot of oxygen compared to your intestines, which extract very little oxygen. Kidneys are different, so different organs are going to extract different amounts of oxygen, which means the venous oxygen saturation will be different in different areas. For example, renal veins may have a different oxygen saturation, not by much, but maybe by 3-4%. The cardiac coronary veins in the heart may have a different saturation. So it all mix at a common point, isn't it, in the right ventricle and the right atrium. So that is where you get the mixed venous oxygen saturation. If they ask you what is the best site for finding out a mixed venous oxygen saturation, you're going to your value must be somewhere around, the answer must be pulmonary artery. Pulmonary artery is the best site, because after all the veins mix, this is the final place. Even after the coronary veins, this is the best site for measuring the mixed venous oxygen saturation. But there is something called your SVC oxygen saturation, IVC oxygen saturation, which are all things we have discussed in detail in the shock section later on. But if you see me right now, the basic is the best site for measuring the mixed venous oxygen saturation is in the pulmonary artery. Very important. So that's why it's very important. You have to be very sure the pulse oximeter measures. I mean, I can write SaO2 also here. So which means SaO2 and SpO2 are to an extent it's equivalent. At the same time, to an extent it's not equivalent as well. So both are measuring the arterial oxygen saturation, but SpO2 is through pulse oximeter and SaO2 is directly through the arterial blood, taking its invasive sample. Arterial blood you take and you put it in the ABG machine and find out this thing. So how the ABG machine does that? Tell me how the ABG machine measures the saturation. How it does that? Simple. ABG machines find out the pulse oximeter. I mean PaO2. It's going to find out the PaO2. Using the PaO2 by using the curve. What curve? It's by using the ODC curve. It's going to find out the saturation. SaO2. This is one type of pulse oximeter ABG machineries do. And the second way how to measure the SaO2 is by photospectrometric methods. Photospectrometric methods, again it can find out the PaO2. But pulse oximeter is going to measure the SpO2 completely by different principle. Pulse oximeter measure the SpO2 completely by, again truly by your LEDs and sensors only. Completely by light emitting diode principle and the Beer-Lambert's law. It's completely different. It's by the Beer-Lambert's law. So a lot of things do affect the pulse oximeter thing. So the gold standard for finding out the exact saturation in the blood is ABG only. But still, for a lot of non-invasive reasons, I mean a lot of reasons like non-invasiveness and rapidity, continuous monitoring and all, we prefer the pulse oximeter right now. So these are the things that are advantages and disadvantages of pulse oximeter. These are things that pulse oximeter can show in your display. So very important. And next thing, if you ask me, there are certain things that are possible. I mean, I will call it troubleshooting, but still, a lot of things that are possible in a pulse oximeter waveform. First thing, you can see improper waveforms. Improper waveforms. Whenever you see an improper waveforms, the most important reason is going to be, let me tell you, simple reason is going to be poor placement of the probe or distraction in the probe. So all these things are going to cause improper, like normally you should get a waveform like this, but if you see some waveforms like this definitely cannot correct. It's whatever the value the pulse oximeter is showing definitely will be incorrect in this scenario. It's not a correct value the reading the pulse oximeter showing, because you should get a proper waveform. So number one, improper placement of the probe. Second thing, you have something called a motion artifact. Again, it's very important because you need to have a, still this thing, then only you can find the blood flow. If you have a motion artifact, again the light emitted will be displaced and the distance will change because of the path length is changing because of the motion. Your Lambert's law will get totally, sagged up, and you might be getting a completely, wrong reading. So motion artifacts are also possible. Number three, in hypoperfusion. So if the blood flow is very low, you will not get. Many times you will encounter in your internship practice and the patient is in shock, you're not going to get a proper waveform. And you have something called a hypothermia. Hypothermia is again a very important thing. Again, because of very low temperature, the vessels may go for vasoconstriction. Because of that, you might end up with a poor waveform. At the same time, there are two more things. One is called a falsely low reading, and second one you have something called a falsely normal or high reading. So two things are also very important to understand: falsely low reading as well as a falsely high reading. Where you are going to get a falsely low reading? So in both these conditions, it may be due to dyshemoglobins. In both these conditions, it may be due to dyshemoglobins. What is a very important dyshemoglobin that's going to give a falsely low reading? The first one is methemoglobinemia. So please pronounce it as methemoglobinemia. It's not a methemoglobinemia. It's a met. Met stands for change. It's a changed hemoglobin. So it's a changed hemoglobin. That's what we call methemoglobinemia. And second one, you have something called a sulfhemoglobinemia. Obviously, third one, you have something called a certain sickle hemoglobins and all. Sickle hemoglobin. And you have something called unstable hemoglobin. Certain unstable hemoglobins also can produce falsely low readings, like HB con. Definitely one of the most common types of unstable hemoglobin, but not in our country. In India, it's very rare. You don't get that. Then next, useless things like skin pigmentation. This is only for completion's sake, but this is not important. Then nail polish, then presence of some vital dyes, like especially the supravital chains we are talking about, this methylene blue. Because why this is important, I'll tell you, because this is a treatment for methemoglobinemia. So methylene blue possible. So methylene blue can lower the saturation, which is used as a treatment for methemoglobinemia. So then you have indocyanine green, or you might get with the fluorescent, because if these are circulating in the blood, again they can interfere with the waveforms, absorption, reflectance, and all these things. It can all completely screw up the Beer-Lambert's law, and you might get into a very wrong waveform, very falsely low. And fifth one, you have severe anemia, venous congestion. In all these scenarios, you might get a falsely low readings possible. So then what are the conditions where you get a falsely high reading? So falsely normal or falsely high readings, the first one is the dyshemoglobin. The moment I talk about dyshemoglobin causing a falsely normal or high reading, it is carboxyhemoglobin. Simple. It's carboxyhemoglobin. The next thing, sometimes very much high HbA1c, that's called a glycated hemoglobin, or otherwise called a, like that's what you see in the diabetic patients, very high HbA1c levels. Because this HbA1c is having high oxygen affinity. I mean, yes, that's true. Like carboxyhemoglobin, HbA1c also has the glycated hemoglobin also has a very high oxygen affinity, to be honest. So that's why these are some of the conditions which produce a falsely low pulse oximeter readings and falsely normal or a falsely high pulse oximeter readings. Very, very important to understand. So why does it causes the falsely low and falsely high pulse oximeter readings? You can see in this particular image. What you can see in this particular image is that this is the red end of the spectrum. You can see that. I mean, if you take the red end of the spectrum, it's very uber cool. You can see this is the spectrum of your methemoglobin. This is the spectrum of the this is the absorption spectrum of a methemoglobin at different wavelengths. And you can see this is the absorption spectrum of your oxyhemoglobin. And this is your absorption spectrum of your deoxyhemoglobin. You can put here deoxyhemoglobin, and this is the absorption spectrum of your carboxyhemoglobin. I can show you here. This is the absorption spectrum of your carboxyhemoglobin. If you see at red wavelength at 660 nanometer, you can see very clearly there are two things that are correlating. One is your deoxyhemoglobin with your methemoglobin. So the methemoglobin and deoxyhemoglobin are correlating at 660 nanometer. Usually, normally the deoxyhemoglobin saturation generally tends to be less, isn't it? You can imagine like that. So since both are correlating at 660 nanometer red wavelength point, so you can clearly see that the pulse oximeter confuses the methemoglobin. The pulse oximeter is going to confuse the methemoglobin with the deoxyhemoglobin. So which means it's going to show a falsely low saturation, right? So which means the absorption, I mean, it doesn't get confused. The absorption spectrum is the same. That's why it gets confused. So that is the reason why you get a falsely low saturation values, because of the hemoglobin. I mean, because of the confusion that happens. Next thing, if you see at this point, you can very clearly see your oxyhemoglobin and carboxyhemoglobin coincide with each other. So which means your pulse oximeter is going to confuse oxyhemoglobin with carboxyhemoglobin, and whenever the carboxyhemoglobin is present, it's going to think it like an oxyhemoglobin, because the absorption spectrum is the same at 660 nanometers. So it's going to tell that the patient is having a falsely high saturation, falsely normal or even a high saturation, because oxyhemoglobin is known to have a high saturation. I mean, oxyhemoglobin means high saturation. So if it confused with oxyhemoglobin and carboxyhemoglobin, even in the presence of a carboxyhemoglobin, you are going to get a high saturation SpO2 readings in the pulse oximeter. So all these things are very important things. So this is the problem with the two wavelength pulse oximeter. So to avoid this, whenever you suspect a dyshemoglobin, for example, if you are suspecting a carboxyhemoglobin, or if you are suspecting a methemoglobin, or you are suspecting a sulfahemoglobin, whatever. So in these conditions, the best thing is to look for the co-oximeter. So if they ask you what is the gold standard for finding out the presence of the dyshemoglobins in the blood, go for the co-oximeter. Co-oximeter is a new, even previously co-oximeters tends to be big, like a big monitor. Nowadays even they are coming like a finger probe, but it's very costly, too costly. That's why many centers do not have this co-oximeter. At the same time, encountering a carboxyhemoglobin, methemoglobin is quite rare. You don't encounter routinely, isn't it? So that's why many hospitals do not have this co-oximeter, but still this is the best for finding out the presence of a dyshemoglobin, which means it's going to, in this case you can see it's almost emitting 7 different wavelengths, isn't it? So 4 to 8 different wavelengths it's going to emit. 4 to 8 different wavelengths it's going to emit, and it's going to analyze the absorption spectrum of every single light in the like photodiode part, and that gives us to a very complicated calculation, and obviously that's fed into the microprocessor, not going to do it. So once the microprocessor realizes that the different wavelengths, so if you're going to emit so many different wavelengths in this particular thing, so when you're analyzing each and every spectrum, the absorption thing, so you can exactly plot a curve itself, and you can accurately tell that this is the curve of the deoxyhemoglobin or a oxyhemoglobin or a sulfahemoglobin or a methemoglobin or a carboxyhemoglobin. It's very easy to tell. So that is why co-oximeter currently becomes the investigation of choice or the standard of choice for finding out a dyshemoglobin. So these are something that are very, very important things. So important knowing about the co-oximeter also is very important. So the next thing what you have to see is on the probe sites. So you can see on the probe sites, this is also quite important. So what you are seeing is the standard probe. So this is the gold standard and very commonly used site you can see in the finger. These are the fingertip probes. So these are the fingertip probes. The same fingertip probes can be used in other sites also, like for example in the earlobes. So there are earlobe probes separately available, or you can use these fingertip probes in the earlobes also, or you can use in the tip of the nose also. These are ALR probes available. You can use in the nose also, very rarely. So these are the other sites, but there are currently, these are new advances where you can use something called forehead probes. Forehead probes are still available, yes, so you can use the forehead probes. So all these things are absolutely possible. So all these things you can use really. So but one thing they might ask you in exams is what is the principle of these forehead probes. Usually the other sites, usually the classic fingertip probes and then ALR probes, nasal ALR probes and the earlobe probes follow the absorption kind of pulse oximeter principle, but here forehead probes has to be based on the reflectance kind of a pulse oximeter. Simple, that's it. So this is what is very, very important to understand. At the same time, the next thing, if you ask me what we're going to tell you, I'm going to tell you one important thing called the SpO2 SaO2 gap. So is there really, this is a true gap or not? Yes, normally there should not be a gap. According to your pulse oximeter, the gap should be less than 5%. This is okay, this is acceptable, which means SaO2 is the gold standard, obviously. SpO2, okay. I mean, it has some pitfalls like what I told you. Normally it should be less than 5%. Anything more than 5% indicates an instrument error usually. But if you have more than 5% gap between the SpO2 and SaO2, it becomes very, very significant. It becomes very, very significant. So in case if it becomes extremely significant, so but if you ruled out an instrument error, then in that condition you can suspect a dyshemoglobin. As simple as that. You can really suspect a dyshemoglobin. Why? Because for example, you have an SpO2 or SaO2. SaO2 is showing a little bit high value and SpO2 is showing a little bit low value, and the gap between them is more than 5%. Here I can suspect a methemoglobin. Why? Because in methemoglobin I told you the SpO2 will be falsely decreased compared to the SaO2. So the standard of standard for comparison is the SaO2, is the arterial oxygen saturation by ABG. Similarly, you have an SpO2 which is relatively normal or high, maybe let us assume it's 100% or 99%, and your SaO2 is showing a bit of low value, not like maybe 94, 93, but the SpO2 is showing high percentage, and if once you rule out your instrument errors and the gap is more than 5%, then in this condition you can even suspect a carboxyhemoglobin. Very important, because I already told you in carboxyhemoglobin the SpO2 may be falsely normal or increased. So SaO2 and SpO2 are not the same. You can equate at some places, but if you see very fine way, it's not the same, it's something different. So whenever you have a saturation gap which is significant, defined by more than 5%, then definitely it is something significant, and you can suspect dyshemoglobins in this scenario after you ruled out your routine instrument related errors and all. So I mean, all the standard instruments tell that 5%, less than 5% is the cutoff. Like all the pulse oximetry instruments give this promise that the difference between the SiO2 and SpO2 will be less than 5% in most cases, but it breaks down during presence of the dyshemoglobins or if the instrument is showing some error. Fine. So this is what we are going to. These are the things we have seen actually. But ultimately, one thing I didn't tell, in cyanide poisoning, the saturation will be normal and the SiO2 also will be normal. There won't be saturation gap because cyanide is not based on your hemoglobin at all. Cyanide is based on the electron transport chain inside the cell, so it doesn't affect the hemoglobin. So don't think there will be some change in the cyanide. There's no false increase or false decrease in a cyanide poisoning. That's also something very important to understand. So the next thing, what I'm going to talk is on the dyshemoglobin. So we are moving on to the dyshemoglobins. So the moment I am going to talk on the dyshemoglobins, the first thing is going to be on the carboxyhemoglobin, or simply I can tell carbon monoxide poisoning. So where you are going to get the carbon monoxide poisoning? Typically in fires. So that's where I'm going to get. So typically in fires, that's where I'm going to get a carbon monoxide poisoning or closed exhaust. Let us discuss. So fires are very important, especially on house fires. So when you are stuck inside like wood burning stoves, for example, this is not seen in our country, but we generally tend to see in previous maybe 15-20 years back when you're working in the PHC, sometimes we do suspect this wood burning related carbon monoxide poisoning. Not so common nowadays, but still it's something worth knowing. So wood burning also can result in. So then motor exhaust, it's going to have a lot of effect because this is the one that is very commonly asked in many Western countries, motor exhaust. For example, whenever you are sitting inside a vehicle, sometimes the motor exhaust may not be working properly and it might start leaking its carbon monoxide back into your through your AC or through some other ways, and you might get stuck inside the motor vehicle and you might go for unconscious and you might die. So all these things are possible. So motor exhaust. Then furnaces, possible, and closed ventilation. Whenever the ventilation is closed, you might encounter this. And pipe smoking. So pipe smoking is associated with a lot of carbon monoxide. Fine. So in all these things. So these are the things that is going to be, like some of the important causes of sources of CO poisoning. Source of CO poisoning. And is there any way you can really detect the carbon monoxide? No. You have no ways to detect the carbon monoxide poisoning because carbon monoxide per se is completely colorless and odorless. Unless carbon dioxide does have some color, because it comes from smoke, but this doesn't, colorless and completely odorless. So, and it's also tasteless. So you can't detect. You can't have any idea about that you're breathing carbon monoxide. There's literally no idea. So pathophysiology wise, very simple. You have iron, hemoglobin. So what is going to happen is carbon monoxide is going to bind with this. Carbon monoxide is going to bind with this one of the ions. So once the carbon monoxide binds with one of these ions, so what happens is others may be bound with oxygen. So but what this carbon monoxide is going to do is very simple. This carbon monoxide bound ion is going to have very high affinity. It's not going to release carbon monoxide. At the same time, it's not going to release the oxygen also. That's what is going to happen. So so what happens really is like when you are bound with carbon monoxide, so the carbon monoxide affinity for hemoglobin is almost 240 to 260 times more than that of the oxygen itself. So it's going to hold the oxygen very tightly. And because the steric hindrances, it's very imperative to know the remaining oxygen also cannot be released. The remaining oxygen also cannot be released because of the steric hindrances. Very simple. So it's going to hold the oxygen very tightly, carbon dioxide very tightly. At the same time, it's not going to release oxygen also because the steric hindrances change in the structure created by the carbon monoxide ion binding. So oxygen is also not released. So if the oxygen is not released, it means ODC is going to shift towards the left. ODC is going to shift towards the left. So at the same time, and if you ask me in the microstructure, if you want to know the pathophysiology at the very, very microscopic level, if you zoom in and see, this carbon monoxide is going to bind with hemoglobin in the Fe2 plus state. It's going to bind to hemoglobin in the Fe2 plus state. So remember, this Fe2 plus has to become Fe3 plus to release O2. Now O2 will be released. So which means the binding of the O2 happens in Fe2 plus. But once the oxygen is released, it becomes Fe2 plus, Fe3 plus, isn't it? So again, it will be reduced back into Fe2 plus. That is different once the oxygen is bound. So that's quite different. So we're not going to talk about that. So here, instead, if you make it carbon monoxide, so Fe2 plus, if it binds with carbon monoxide, it will not allow the ion to change into Fe3 plus configuration, because carbon monoxide, if they ask you at what state it binds, the answer is Fe2 plus. So again, it is going to bind in the ferrous configuration only. When the ion is in the ferrous configuration, carbon monoxide binds, it will not allow the ion to change into Fe3 plus. If it's not going to change in the Fe3 plus, oxygen release is not going to happen for sure. So that is the reason why the ODC shifted to the left, and that is the reason why it is said that carboxyhemoglobin is going to have a very high oxygen affinity, and this is what we are going to call it as something called a carboxyhemoglobin. So which means there are two things you can see. One site is occupied by carbon monoxide, which means overall oxygen carrying capacity is less. So overall oxygen carrying capacity of the hemoglobin is decreased because one side is occupied. Only 3 sites are full with oxygen. At the same time, oxygen released to the tissues is also reduced. Oxygen released to the tissues is also reduced, which means a lot of the tissues are going to go for hypoxia, and because of the same fact, the ODC will be shifted to the left. Shift of ODC happens to the left. And number 3, if you ask me, carbon monoxide doesn't only bind to hemoglobin, it also binds to myoglobin also. It also binds to myoglobin also. Myoglobin also cannot release oxygen, which means the most important thing, in a critical scenario, myoglobin is important for cardiac muscle more than a skeletal muscle in the critical scenarios. So even the cardiac muscle goes for hypoxia. So the cardiac muscle also goes for hypoxia, cardiac ischemia and cardiac hypoxia, which might result in low cardiac output, and ultimately you can even get a cardiac arrest. Absolutely possible, all these things. So these are the scenarios that are truly possible. Apart from that, it's been said that carbon monoxide also does your cytochrome C oxidase inhibitor. Carbon monoxide also said to inhibit the cytochrome C oxidase enzyme. So it also blocks the cytochrome C oxidase enzyme. So your oxidative phosphorylation also shuts down the mitochondria, which means it causes hypoxia at the cellular level also. Because at the basic preliminary physiology level, you might be thinking histotoxic hypoxia means only cyanide. But carbon monoxide also is, to an extent, contributes to the histotoxic hypoxia by blocking the cytochrome oxidase, and cellular level hypoxia is also possible. And number 3, it also inhibits the cytochrome P450. Cytochrome P450 in the brain. So since it blocks the cytochrome P450 in the brain, so you can result in lipid peroxidation and inflammatory damage. So you might result in this condition, you might result in a lipid peroxidation and inflammatory damage in the brain. So you might get knocked out and completely you might lose consciousness. These are supplementary things. These are not very important. So basic important mechanism is all these 3. So these are the things that are very, very important before understanding a carbon monoxide. So the next thing what you have to see is the clinical features of CO poisoning. So what could be the clinical features of carbon monoxide poisoning? Typically the carbon monoxide poisoning symptoms depend on the levels of the carbon monoxide. So what are going to be the levels of carbon monoxide and the symptoms? So I can tell the carbon monoxide level, I can tell the clinical feature, I can tell the symptom. So if the carbon monoxide levels are less than 10%, the patient will be completely asymptomatic, and the patient is going to show only mild headache, maybe mild headache, probably a dizziness, that's it, probably a dizziness. If you ask me, what is the carbon monoxide levels that you are exposed in a metropolitan pollution? When you're going, traveling in a heavy traffic in a metropolitan traffic, what is the level of carbon monoxide you expect? It's astonishingly in cities like Delhi and all, it's been proved that the carbon monoxide levels goes up to almost 15 to 25% sometimes. So that is the reason whenever you travel in a bike in a metropolitan traffic, you might get a lot of headache and dizziness. That probably not due to the tiredness you get, that might be due to the carbon monoxide inhalation also. And don't worry about it, it's going to get better over time, but it's not the case in when you're breathing continuously for a long time. That's different. At the same time, if you ask me an average smoker, if you ask me the blood of an average smoker, how much carbon monoxide is contained? Almost 20%. Carboxyhemoglobin you might see in the blood of a smoker itself. So how the smokers don't get any symptoms? at all? So if you ask me why the smokers do not get any symptoms in the first place, it's all depending on the what is the adaptation mechanism for this people you're going to see. So if you ask me the adaptation principle, what is going to happen in these people, why they don't develop hypoxia in a smoker, for example. Let us assume this is a normal person and this is a smoker. Normal, you know very well. So this is going to be, for example, a deoxyhemoglobin, and this is going to be oxyhemoglobin. So I can tell arterial blood we are talking about. So let us assume this is the deoxyhemoglobin and this is the oxyhemoglobin. You can see maybe 98% is oxyhemoglobin. You can see 98% and this is oxyhemoglobin. But what happens in a smoker? Let us assume the deoxyhemoglobin remains the same. So this is the deoxyhemoglobin level. And you can see this is the carboxyhemoglobin level maybe. I can put it in pink. So this is the carboxyhemoglobin level. So you can see this is the carboxyhemoglobin and this is the deoxyhemoglobin. And this is the oxyhemoglobin. Oxyhemoglobin, which still remains the same. There is no change in the oxyhemoglobin. Still the oxyhemoglobin content is same, which means they are going to protect the patient from the harmful effects of carboxyhemoglobin by producing an adaptive response called polycythemia. This polycythemia is due to, initially they also would have same amount of hemoglobin. The same amount of hemoglobin would have contributed to the tissue hypoxia, that would have increased the erythropoietin. That increase in erythropoietin will cause polycythemia. Polycythemia will maintain the normal amounts of oxyhemoglobin in these patients, as simple as that. So this is an adaptive mechanism in a smoker. So why I discuss this, to just parallelly understand all these concepts also. So less than 10% patients generally tend to be asymptomatic. With the range of 10 to 30%, patients might develop fatigue, patients might develop headache, patients might develop a little bit of nausea and vomiting. All these things are possible if it's a little bit higher. So if in the range of more than 30%, patients may go for agitation, confusion, somnolence, dyspnea and chest pain. Which means typically you are going to get symptoms of CNS breakdown and cardiovascular breakdown. So this is what is going to happen when the levels exceed 30%. When it exceeds 50%, so the patient is going to go for shock, respiratory failure, myocardial infarction, seizures, and probably a coma. And if you're not going to do anything, the patient is going to definitely a dead duck. So more than 50%, usually the patients die in 30 minutes. If it's more than 70%, the patient's going to die in just 3 minutes. So such a high level exposure to carbon monoxide is going to kill you in minutes, more than 30%, 100% within 40 seconds, as simple as that, you're going to die. So no doubt about that. So this is the this thing about the carbon monoxide, this is the clinical features. Apart from that, you might see a cherry red discoloration of the skin, cherry red discoloration. So this cherry red discoloration of the skin, you might even see a cherry red spot in the macula. That's what your opthal textbooks give. But surprisingly, the cherry red discoloration of the skin as well as the cherry red spot in the macula, all these things are surprisingly very rare clinical finding, to be honest. We have seen a lot of carbon monoxide poisoning cases, but surprisingly very rare finding. You don't generally get these findings when you see a clinical. It needs a high degree of suspicion to find out. The proper history is very important again. That gives the clue for carbon monoxide poisoning. Second thing, the history is very important. That's why I'm telling you, whenever you have an history of this inhalational injury, especially this fire, like the necrosis of the throat and tongue and all these things, whenever you have an inhalation injury, this strongly suspect carbon monoxide poisoning in these patients. And at the same time, there can be associated coexistent cyanide poisoning also. It's very important because cyanide poisoning also happens currently due to house fires. Apart from the bioterrorism, apart from the terrorism you get, the cyanide poisoning is also common in house fires. So that is the reason the patients may have associated cyanide poisoning also. At the same time, even in post-mortem, when the patient dies, the cherry red discoloration of the skins are very common in carbon monoxide poisoning. So the cherry red is a clue in exam, that's it. But even though it's not a common finding, very common in the post-mortem after the death, but not before death. In the clinical scenario, it's very rare. So when you are talking about investigations and diagnosis, if you want to diagnose a carbon monoxide poisoning, the first thing in acute carbon monoxide poisoning, what are things you're going to get? The first thing is patient will be having all the CNS symptoms, respiratory distress. All these things are possible in acute scenario in heavy poisoning. In this condition, CNS symptoms, patient generally has brought to us in coma. The history is the one that gives the very important clue. So in acute scenarios, findings what you're going to see is SpO2 is normal or even falsely increased. Usually, often the SpO2 will be at 100%, very common. And you will have a saturation gap, SpO2 and SaO2 gap will be more than 5%, very important. Saturation gap may be there. This is clue number 1. Clue number 2, you can see HAGMA, isn't it? That's called high iron gap metabolic acidosis. That is due to tissue hypoxia. The patient, the cells will go for anaerobic metabolism and generation of lactic acid, resulting lactic acidosis. So you might result in a low pH with an increased anion gap, absolutely possible. That is due to elevated lactate, high iron gap metabolic acidosis. At the same time, patient will have a normal PaO2. This is a very, very, very important clue. Patient will have a normal PaO2 because carbon monoxide does not affect the dissolved oxygen. It's going to affect only the oxygen released from the hemoglobin, but the dissolved oxygen is normal in a CO poisoning. For that matter, in any dyshemoglobin, dissolved oxygen will be normal. The problem is the hemoglobin, not the dissolved oxygen. The third thing what you're going to see is the co-oximeter. This is done in high degrees of suspicion in a co-oximeter. Suppose in how much you can take, because it can tell the COHB levels, exact carboxyhemoglobin levels in the blood. So what is the normal carboxyhemoglobin? If it's a non-smoker, it's less than 3%. If it's a smoker, it is less than 10%. Maybe you can tell 15, maybe. If 10 might be a very low thing, I think it's 15. So in a smoker, you can keep a cutoff of even 15%. I think recently the Humphreys values are they say okay fine, so less than 15% is the one you see in the smokers, less than 3% in a non-smoker, and less than 15% in a smoker. So these are the things that are important. But in a chronic carbon monoxide poisoning, what you will see, chronic carbon monoxide poisoning, for example, this typically happens in a smoker. So obviously you are going to see only one finding, that is polycythemia. You're going to see only polycythemia. That's the only thing you will see. Apart from that, you can use a co-oximeter in this principle, but in these cases, but still I don't think it's really necessary, because in a chronic smoker, you have a polycythemic response which maintains the oxyhemoglobin in the normal range. So generally they will be asymptomatic. They won't have any symptoms. So it doesn't need to be treated also. The moment you stop the smoking, the carboxyhemoglobin levels slowly drop down to baseline, and the polycythemic response also may decline. So anyway, we are not going to discuss about that right now. And what is the treatment of carbon monoxide poisoning? The first treatment, you have to give 100% oxygen. Typically we use NRBM, that's called non-rebreather mask. So NRBM related 100, this is the only thing, in a non-invasively, to achieve 100%, one of the standard ways is NRBM, which provides very high oxygen, 85 to 100% practically. So NRBM is very important. So you give 100% oxygen to displace to try to displace, at least by giving hyperoxia, to increase the PaO2 as much as possible, so that you might somehow competitively at least replace the carbon monoxide from the iron. So 100% oxygen. Plus or minus, you can use hyperbaric oxygen therapy. Hyperbaric oxygen therapy. So what do you mean by hyperbaric oxygen therapy? So what are the indications if they ask you in hyperbaric oxygen therapy? The first one indication is if the carboxyhemoglobin levels are more than 25% by co-oximeter, or if pregnant, if it's more than 20% if pregnant. So the cutoff is a bit low in pregnant patients. So carboxyhemoglobin more than 25% or more than 20% if the patient is pregnant. Second one, if the patient is having end organ ischemia, some organ related ischemia is there. For example, if the patient is having neurological features, the patient is having cardiovascular manifestations, distressed patient, respiratory distress, in all these conditions you can add an additional carboxyhemoglobin. At the same time, in patients who are having severe acidosis, by definition, if the pH is less than 7.1, you can get a this also becomes an indication for a hyperbaric oxygen therapy. Hyperbaric oxygen is very simple, 100% oxygen, but you give it in a very high pressure. That's all. So you don't give in a normal atmospheric pressure. 760 millimeters of mercury is a normal 1 atmospheric pressure. You get 2, 3, 4, even 5 atmospheric pressures. Same 100% oxygen is given very high pressures. You call it as hyperbaric oxygen. So this is one indication for hyperbaric oxygen therapy is carbon monoxide poisoning, and these are the indications for the hyperbaric oxygen in a carbon monoxide poisoning. So similarly, if there is evidence of low GCS, definitely the first thing you're going to do is intubate the patient, because obviously when the patient is in coma, don't get fogged by the exam. Even if they give carboxyhemoglobin levels of even 70%, if the patient is in coma, I will tell you the first thing you do is intubation, because saving the life of the patient is most important, because this is for airway protection rather than giving oxygenation. So very, very important. Low GCS means it is intubation. The first step will be intubation. Then you can go for your 100% oxygen, hyperbaric oxygen, all these things. That doesn't mean anything. So anyway, so these are the things that you have to know about the carbon monoxide poisoning. And the next thing I'm going to talk is on the methemoglobin. Methemoglobinemia. That's the next thing we are going to talk about. So the moment you know about met, I again told you, don't pronounce as meth, it's methemoglobinemia. Met means changed hemoglobin. So what is the thing that is changed here? Similarly, as simple as that, you have Fe2 plus, you have an Fe2 plus here, all Fe2 plus, but one ion molecule is replaced to one particular ion molecule is going to be replaced with Fe3 plus. As simple as that. It is in the ferric form. That is in the oxidized form. Normally, Fe3 plus should be bound to the, Fe3 plus means whenever the oxygen is bound, you might get an Fe3 plus, but not when the oxygen is not bound. So which means, what do you mean by oxygen? You have a simple thing called Lioger. You know very well, whenever there is a loss of electron, that is what we refer to as oxygen. So the moment whenever oxygen binds, you're going to get Fe3 plus, because the oxygen is going to oxidize the ion and change from Fe2 plus to Fe3 plus, which means Fe2 plus, when you lose one electron, that is loss of electron. This is what is said to be oxidized, and this is what we are going to call as Fe3 plus. And whenever oxygen is added to the ion, oxygen knocks an electron out, which means it's going to oxidize your Fe2 plus, and the oxygen will be carried in a Fe3 plus way. So which means what is going to happen in these patients is that they are going to, when they come back, for example, I have to tell this also, when the oxygen is released, you will add one more, you are going to add an electron, and again the ion is going to become, the moment oxygen goes, it leaves one electron back to the ion. So the ion is going to go back to the Fe2 plus state, which means oxygen can bind only in the Fe2 plus state. It can't bind in the Fe3 plus state. So since at the baseline, if you ask me at the baseline, your ion in the hemoglobin should be in the Fe2 plus state, not in the Fe3 plus state. So if at the baseline level itself, if your ion is in the Fe3 plus state, this is what we refer to as methemoglobin, which means the ion at the baseline, not in the ferrous form, it's in the ferric form. At the baseline itself, it's in Fe3 plus oxidized form. This is what we call it as methemoglobin, and this is going to affect a lot of things. For example, it's going to affect the oxygen carrying capacity of the hemoglobin itself. For example, since this is in oxidized form, in Fe3 plus form, for example, if you're going to add ion, what's going to happen, add oxygen, what's going to happen is, it's going to become Fe3 plus oxygen bound. This is not going to carry oxygen for sure, because only Fe2 plus can carry oxygen. This is the already oxidized ion even in the resting state, so Fe3 plus can't trap the oxygen, so it can't bind with oxygen, so it's going to be like that. And you have Fe3 plus, again oxygen bound to this, and Fe3 plus, again oxygen bound to it. So this is what is going to happen. So there are two interesting things that are going to happen here. The first very interesting thing that's going to happen here, this has to normally shift back to this by releasing oxygen. This has to normally shift back to this, then only you can have an oxygen release. Then only you can get an oxygen release. But the problem is this Fe3 plus will strongly have some steric hindrances. So this Fe3 plus is going to cause some steric hindrances that is going to prevent this molecules from release of oxygen, which means it's going to reduce the oxygen release to the tissues, which means the oxygen release is decreased, means the tissues are going to go for hypoxia for sure. At the same time, since this one ion out of 4 in this particular hemoglobin molecule is useless, this ion is not carrying oxygen, at the same time it's not allowing the other ion molecules to release the ion also. Once it's a held ion, it's not going to allow the other ion molecules to release ion as well. So this is the reason why, two interesting things will happen. One, the oxygen carrying capacity, if you ask me, the oxygen carrying capacity of the blood will be decreased, number one, very important. And number two, the oxygen dissociation curve will be shifting to the left, that's what's going to happen. So it's not going to allow the other oxygen molecules to be released also, which means they're going to have high affinity for oxygen, and when you have a high affinity for oxygen, that is what we refer to as something called a ODC shift to the left. So the oxygen dissociation curve is going to shift to the left. It's not going to release oxygen at all. And these are the things that are going to contribute to the hypoxia in the first place. Clear? So very, very important points, all these things. So apart from that, knowing about the basics of the methemoglobin, you also have to know, normally is it possible to have a methemoglobinemia? Normally possible to form a methemoglobin in the body? Yes, because you have a lot of oxidizing substances. Oxygen itself is an oxidizer. It might cause Fe3 plus and it might get out of the hemoglobin also, and the hemoglobin might not get converted back to your Fe2 plus. And if it doesn't happen, then you're doomed, isn't it? So normally there are a lot of things that happen in your body that prevent the formation of this methemoglobin. For example, if you have a HB in the hemoglobin in the Fe2 plus, I already told you, and you have hemoglobin in the Fe3 plus form. This is what is oxygen bound. So this is what is going to create oxygen, and it's going to form an oxygen superoxide. It's going to form an oxygen with the superoxide oxygen, and this is what is going to be bound with and this is the oxygen that is bound with the hemoglobin. And this oxygen, taking on extra electron results in loss of electron, causing that extra positive charge, that is Fe3 plus. This is what we call an oxidized ion in the oxygen bound form. So but this is where you are going to add the oxygen here. So this is the oxygen that is free oxygen bound to the hemoglobin is becoming a this oxyhemoglobin form, that is ferric form. So but when it comes back, it has to, this is not a good thing, because this formation of this ferric is not a good thing, because once this oxygen gets out, once the oxygen is out of the ferric ion, once the oxygen gets out, for example gets out, normally what happens, it comes back to this usual ferrous form. But if it doesn't, there are a lot of possibility that it might not go back to the ferrous form. So our body has a lot of defense mechanisms to prevent this Fe3 plus formation, because if it Fe3 plus formation, you will have a methemoglobin. So you can't get methemoglobin. You should not allow this methemoglobin, and a lot of defense mechanisms are in the body which maintains methemoglobin levels to less than 1% of the usually. So how they do that is by two mind-blowing principles. One, whenever it is detected, you have an intrinsic enzyme that is called cytochrome B5 reductase. Otherwise, this is also referred to as something called a methemoglobin cytochrome B5 reductase. which is going to convert this ferric form to ferrous form. How they're going to do that is by using the NADH principle, by using the NADH to NAD plus. So this is what is going to happen. So what you're going, I mean, this is something, a lot of chemistry, but it's worth understanding a little bit. So if you ask me, this hydrogen ion is what the key is. It's a neutral thing. Hydrogen ion is going to have one proton and a solitary electron that is going to orbit around. So the moment you tell NAD plus to, I mean NADH to NAD plus, which means this proton is going to go into this and this into the NAD, and this electron is added to the compound. So this process gives one electron. This one electron is the one that is added to the Fe3 plus. So in turn, the hemoglobin becomes Fe2 plus. As simple as that, isn't it? So which means you are reducing the ferric ion, like you are reducing that into, because I told you as the Liouville principle, gain of electrons is called reducing. So now the hemoglobin is reduced back to Fe2 plus. That's why going to oxygen has oxidized the hemoglobin to Fe3 plus. Now you have reduced the Fe3 plus to Fe2 plus form. So which means it's going to do that. So this hydrogen plays a key. And similarly, you have another mechanism. For this, the most important enzyme you can tell is the cytochrome B5 reductase, which is the one that prevents, like the accumulation of methemoglobin in the body, even under normal circumstances. So now, next thing what you can do is this Hb can be changed to, Fe3 plus can be changed to Fe2 plus by another principle. This another principle is what we refer to as something called NADPH NADP plus mechanism. So you have NADPH and NADP plus. By the same mechanism, this hydrogen, the proton comes here, but the one electron is added, which means it results in a reduced ferric ion to ferrous form. So that's what is going to happen. For this, you need a very important enzyme that is called NADPH methemoglobin reductase. So this is the very important enzyme that's going to change this ferric to ferrous form. So which means it prevents the accumulation of methemoglobin in the blood in the normal person. So, but you know very well that where this NADPH comes from, the NADPH is going to come from one important thing. You write NADP plus here, and NADPH is formed by a very important reaction that change from glucose 6 phosphate to 6-phosphogluconate. And who's catalyzing this reaction? It's a very simple question. Who's going to catalyze this reaction is the G6PD. So by G6PD, you are going to generate this NADPH, which you have seen already in the last thing. And that is one of the other reasons why this NADPH production in the RBC is very, very important, because hemoglobin is persistently, getting into oxidation stress. So very, very important. So which means in a G6PD deficiency, you might get a methemoglobinemia. Even in a cytochrome B5 reductase, all these things may result in a congenital forms of methemoglobinemia, absolutely possible. And that is also one reason, if you ask me how this methylene blue works. So because this in the same diagram, I can write one more thing also. There is one thing that really works for methemoglobinemia, that is methylene blue. That is new methylene blue dye, the same thing that used as a supravital stain, because this is going to activate the NADPH methemoglobin reductase. And this is what is considered to be the treatment of choice for methemoglobinemia. As of now, this is the best treatment for methemoglobinemia, because this is going to activate the NADPH methemoglobin reductase enzyme. So once it activates this, the conversion of ferric ion to ferrous ion will accelerate. So that is how methylene blue works. But one pitfall of using methylene blue is absolutely contraindicated in G6PD deficiency. You cannot give methylene blue in a G6PD deficiency, because if you don't have NADPH, for example, even if how you can accelerate the enzyme? Even if you stimulate the enzyme like hell, for example, if you are stimulating the enzyme very, very much, but you don't have this NADPH, because in G6PD deficiency, you are not going to produce NADPH. If you don't have NADPH, that is the essential substrate, that is the essential thing for this enzyme to work in the first place. If it's not there, NADPH itself is not there, this methylene blue will not work, this methylene blue is not going to work in G6PD deficiency. Definitely it's not going to work in G6PD deficiency. If it's not going to work in G6PD deficiency, then this methylene blue itself is a mild oxidizing agent. This methylene blue itself is a mild oxidizer, which means it can further worsen the methemoglobinemia in the first place. So do not give methylene blue when the patient is having a G6PD deficiency. Very, very important point. It's contraindicated in G6PD deficiency. You can't give methylene blue in a G6PD deficiency. All these things are very important. So the next thing, if you ask me about the causes of methemoglobinemia, so if you ask me about the cause of methemoglobinemia, at levels of 0 to 5%, it's going to be completely asymptomatic. At levels of around 5 to 10%, it's going to cause cyanosis. At levels of 5 to 10%, it's going to cause cyanosis. At levels of more than 20%, it's going to cause CNS symptoms. Little bit of CNS symptoms. CNS symptoms will start, like the patient might get anxiety, a mild headache, and dizziness possible. At the same time, this is the time where one of the typical findings of methemoglobinemia will get, that is called chocolate brown discoloration of the blood. Chocolate brown discoloration of the blood, very common, which I'll show you in some time. Next, when it exceeds more than 50%, you're going to get shortness of breath, confusion. That's because of hypoxia. At the same time, when it exceeds 50%, the patients will develop seizures, arrhythmia, and probably death as well. So this is what is going to happen. So if somebody asks you what is the absolute level of methemoglobin, absolute methemoglobin level to cause cyanosis. This is a standard question many times in your clinical postings. Absolute methemoglobin level to cause cyanosis, it is 1.5 grams per deciliter. Once the hemoglobin, actual hemoglobin, I'm talking about the percentage, when the actual hemoglobin exceeds 1.5 grams per deciliter, that is the cutoff for developing a cyanosis. Similarly, if they ask you how much deoxyhemoglobin when it exceeds cause cyanosis, answer is 5 grams per deciliter. For methemoglobin, it is, I already told you, it is 1.5 grams per deciliter. If it's a sulfhemoglobin, it's going to be 0.5 grams per deciliter. These are the absolute cutoffs for developing a cyanosis in a patient who's having a abnormal hemoglobin like one of this. So what are the causes? So what are the causes you're going to get? So sorry, this is what the clinical features are talking about. So what are the causes? Let me come here. So what are the causes of a etiological factors of a methemoglobinemia? Etiological factors very commonly is due to drugs. So certain substance exposure. For example, the first one is the nitrates. Second one, usually nitrates are very high in well water. So many times in certain wells, not all the wells, well water, when you're taking nitrates from wells, when you're taking from the wells, not bore wells, when they're in the wells because of the surrounding environmental contamination, you might have a lot of nitrates in the well water. So this is very important point. So nitrates from, very likely this nitrate contamination may be environmental completely. And certain preservatives, apart from the well water, you can get this nitrate contamination in certain preservatives also. Like for example, especially preservatives that are used for meat, for cheese, all these things. Because these preservatives may be partially converted to nitrate in the GIT by the intestinal bacteria. So that is also possible. So nitrates, very, very important. Nitrate contamination. So then you have something called, a lot of drugs are there. The drugs, these are very important because a lot of drugs can produce methemoglobinemia. One is sulfonamides. Then you have dapsone and clofazimine, which are anti-leprosy drugs. Dapsone and clofazimine. Then you have nitric oxide, inhaled nitric oxide a lot of times. Then you have topical anesthetics. Topical anesthetics like benzocaine, lignocaine, and all these things, lignocaine. Then you have aniline derivatives. Then you have anti-malarial drug called primaquine. All these things can cause. Then certain benzene compounds, also can cause. Or else if you ask me the two most important things, that is dapsone and benzocaine lignocaine. These are the two important things that are tested in exam, because usually in exam, if they give a history of leprosy, suddenly patient comes with, started with the treatment for leprosy, patient comes with dyspnea and chocolate brown color, your saturation is low, go for methemoglobinemia. Very important. Similarly, this is also very important because many times these anesthetics are used for endoscopy. So very common question. So the moment, in the examiner, if they ask you, the patient is undergoing a procedure for endoscopy. Once the patient is undergoing a procedure for endoscopy, during the procedure itself, the patient develops cyanosis, shortness of breath, and the blood shows chocolate brown color, saturation drops. What is your probable diagnosis? Answer is methemoglobinemia, and you're going to give IV methylene blue as soon as possible. That's the treatment. And fourth one, you can tell a lot of congenital causes. In congenital methemoglobinemia, two things are there. One is called this cytochrome B5 reductase deficiency. Cytochrome B5 reductase deficiency. Normally itself, cytochrome B5 reductase is low in newborn. So, I'm not talking about the deficiency. Even physiologically, the cytochrome B5 reductase enzyme is actually low in the newborns. So, a newborn might develop a methemoglobinemia much faster, especially when they are giving the local environmental water contaminant. That's why breastfeeding is again of paramount importance. 6 months exclusive breastfeeding is very important. But at the same time, newborns receive some environmental contaminated water. The newborns are at very high risk of developing methemoglobinemia. But apart from that, children may concurrently have a congenital this deficiency of this particular enzyme as well. Second thing in G6PD deficiency, which I told you the mechanism already. Then how we are going to diagnose this methemoglobinemia? The first thing, you are going to see something called a low SpO2. The falsely low SpO2, usually it will be falsely low. That is because of the interference of the methemoglobin with the absorption spectrum of the deoxyhemoglobin. Both looks the same. That's why your pulse oximeter might mistake your methemoglobin for deoxyhemoglobin. At the same time, you might have SpO2 which is low, so there might be a saturation gap. SaO2 minus SpO2 may be more than 5%. In this case, SaO2 will be a little bit higher and SpO2 will be falsely a bit lower. So it might be more than higher. Significant saturation gap also might give a clue. And then you might have something called a chocolate brown discoloration of blood. So chocolate brown discoloration of the blood, which I will show you, that is due to presence of methemoglobin in the blood. And number 3, you might even, you can use a co-oximeter to finally find out the exact amount of methemoglobin circulating in the blood. So that's also possible. So this is the slide that is showing your chocolate brown color. For example, these are the blood with serially decreasing. These are the blood with serially decreasing methemoglobin levels. So you can see the blood which is having maximum methemoglobin concentration in the blood is typically showing this chocolate brown color, and this is also, yes, a little bit chocolate brown. Yes, good chocolate brown. This is a little, but this is a normal one. This is a normal, which means undetectable methemoglobin. It's classically, typically red in color. That's normal. So chocolate brown is not the normal one. The arterial blood will look like this. I'm not talking about the venous blood. The arterial blood is going to look like this in a methemoglobin. So what's the treatment for that? So treatment for that is going to be, number 1, methylene blue. Methylene blue, that is the treatment. IV methylene blue, typical dose is 1 to 2 ml per kilogram. That is a typical dose. Remember, please do remember, this methylene blue is contraindicated in G6PD deficiency. But if they ask you in exam the treatment of choice, answer is methylene blue. As simple as that. This IV methylene blue is the most important, because IV methylene, told you methylene blue stimulates the NADPH oxidase enzyme, and it itself gets reduced to something called leucomethylene blue. That's a different chemistry, but anyway, that's a treatment of choice for a methylene blue. So methylene blue sometimes can result in two things. It might falsely lower the saturation itself. For example, patient when it's suspected a methemoglobinemia, typically the patient's SpO2 will be 85%. I didn't tell you this, but still very important. Typically the patient's hemoglobin will be maintained at around 85%. That will be the classic SpO2 in a methemoglobinemia. But giving a methylene blue, if you are giving a methylene blue, transiently your saturation might fall actually. Your SpO2 might even decrease. That is because methylene blue itself interfaces with the pulse oximeter wavelength. It itself interfaces with the pulse oximeter wavelengths, and that is the reason why SpO2 after giving methylene blue might even appear falling, but actually it's the treatment. But don't get fooled by all these things. So this is going to fall. So next thing, other agents that are not that effective but still you can use is ascorbic acid, that is vitamin C. At the same time you can use riboflavin also. To an extent all these things are effective but not that effective like methylene blue. And last resort, you can do something called an exchange transfusion, where you can completely change the hemoglobin itself, taking out and giving a fresh hemoglobin which is having Fe2+. So exchange transfusion, all these things are very, very possible as well. So these are things that are again very, very important. And final thing that we are going to discuss is on the cyanide poisoning. Final thing what we are going to discuss is the cyanide poisoning. So what about the cyanide poisoning? So what really happens in the cyanide poisoning is something, this is what is going to happen. So this is a very important thing. Cyanide is going to block your cytochrome 4 complex. This is where your cyanide blocks. Cyanide is going to, how it's going to block is going to bind, because this cytochrome 4 complex is also, 3 is having heme and 4 is also going to have heme. But how cyanide is going to have, cyanide is having high affinity for heme as well. So it binds with the, cyanide binds with the heme and it blocks the complex number 4, and it's going to prevent the cellular respiration. It's going to completely block the cellular respiration, and it blocks the electron transport chain and oxidative phosphorylation. It causes a cellular hypoxia, histotoxic hypoxia and cell death. So this is how cyanide is going to work. So where you're going to suspect, what are the source of cyanide? Cyanide typically again is very important in house fires or any fires for that matters. Any fires for that matters, you might result in cyanide poisoning. At the same time, one important drug that you have to know is sodium nitroprusside. This is a very important thing for exams, this sodium nitroprusside. This nitroprusside, especially if you are using for a long term and at a very high dose. In this condition, there is a lot of realistic chance that you might get a cyanide poisoning. This nitroprusside is a very important precipitator, in exam favorite again. In nitroprusside, patient develops hypoxia, go for nitroprusside. And next thing, a lot of industrial exposures are there, especially from plastics and wool, possible, and even electroplating has a chance of cyanide poisoning. Electroplating has a chance of cyanide poisoning. Some natural source of cyanide are also there. You have naturally called cassava. Cassava is also a very important thing, and you have something called a compound called amygdalin. This is otherwise called as something called lateral, otherwise called as vitamin B17. This is very famous actually, because once upon a time it was thought to be one of the breakthrough discoveries for cancer treatment and all. But right now, no. Right now you don't have all these things. Right now you don't use this amygdalin and all. It's still available in even Amazon, but still this is not the treatment for cancer. So anyway, obviously, so this can result in cyanide poisoning. Probably they thought like this amygdalin selectively causes cyanide uptake by the cancer cells, and that cancer cells selectively die after giving this vitamin B17 lateral and amygdalin, and that's what they thought, but actually it's not the fact. So remember, and at the same time, cyanides can be absorbed through skin, cyanides can be absorbed through respiratory tract, and cyanides can be absorbed through the GIT mucosa as well. So cyanides can be absorbed by a lot of areas, different areas. And if you ask me about the toxic doses of cyanide, so if you ask me about the toxic dose of cyanide typically is in the inhalational route. Inhalational route, it is 100 parts per million. If you are exhaling, you are inhaling for at least 30 minutes, or if it's 300 parts per million, if you are inhaling for 5 minutes. Oral, if you ask me, if it's 1.52 milligram per kilogram, anything exceeds that is going to cause poisoning. At the same time, in dermal skin, I told you it can be absorbed through skin also. Anything more than 100 milligram per kilogram is the toxic dose. This is the breakthrough. At the same time, IV route. IV is usually due to sodium nitroprusside infusion. So if it exceeds 5 to 10 microgram per kilogram per minute of cyanide load for at least 3 to 10 hours, you might result in fatal cyanide poisoning. All these things are absolutely possible and feasible. And next, going on to the clinical features of cyanide poisoning, I rush through. Typically, after oral ingestion, if you have an oral ingestion, the symptoms generally start after around 15 to 60 minutes, which means it starts a bit late oral. It's not immediate. But if it's a inhalational route, it can start in seconds. Very fast inhalational route. That's why many times cyanide is taken in the inhalational route, especially you want to kill someone in terrorism and all, they use in the inhalational form rather than the oral form. Oral form doesn't kill, on the contrary, the belief that they broke open and drink it, you die immediately. Not like that. Definitely doesn't happen. It takes place after a long time. Only the inhalational route cyanide is going to kill you faster. So clinical features, even though this is very rare, this breath smells of bitter almonds. I have not seen, but still, it's a very classical MCQ in the exam. Breath smelling of bitter almonds, very, 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 very important. So this could be there, but unfortunately, this is not a very common finding, and you cannot smell the breath of all the patients in suspected cases. So, and many people even don't know what is the smell of bitter almonds. So don't take it as a very serious thing. At the same time, the patient may develop neurological issues like seizures, coma, altered sensorium. The patient may develop a cardiovascular symptoms. Patient may develop cardiac symptoms like chest pain, arrhythmias and all. Patient may develop a gastrointestinal symptoms like nausea, vomiting, all these things. Patient may develop even bright red bleeding on the mucous membranes. Bright red bleeding on mucous membranes. Patients may develop flushing of the skin. Patient may develop even necrosis in the mouth and esophagus. This is actually one of the old MCQs, necrosis in the mouth and esophagus. This is, I can underline it, necrosis of the mouth and esophagus, important for exam. So this is one of the old MCQs that told it. And not only bright red, and you can see bright red retinal veins. The bright red, why I'm telling is because the oxygen is not utilized. Even venous blood may look very bright because the oxygen is not utilized at all by the capillaries. And if you ask me, even the SpO2 may be very higher. The mixed venous oxygen saturation may be very high because it may be 80-90% also, because the oxygen utilization by the cells is very, very poor, and the oxygen extraction by the tissue is very poor in cyanide poisoning because it blocks the electron transport chain. And similarly, you might even get bright red retinal veins on fundus, and similarly you can get this cherry red skin even here also in post-mortem appearance also. Very simple, again it's due to poor extraction of oxygen. Again, the blood contains a lot of oxygen because the tissues can't utilize them. So that's why this cherry red discoloration of the skin in the post-mortem again is very, very possible. And one of the important classical hallmarks of cyanide is something called the cherry red liver mortis, the bright red liver mortis, maybe in whatever way you pronounce. So this is also very important finding for exams in case of a cyanide poisoning. And if you ask me the investigations and diagnosis, investigation wise, the PaO2 can be completely normal. Similarly, it doesn't affect hemoglobin or even the dissolved oxygen. Is going to affect only the cellular respiration. So PaO2 must be normal. By definition, the patient will have a normal SaO2 and patient will have a normal SpO2 as well, which means there is no saturation gap. Or you can tell the SpO2 SaO2 ratio, the difference will be less than 5%, or which means it's normal. There's no saturation gap at all because it doesn't affect the hemoglobin at all. That's what is very important. But the patient will show severe high ion gap metabolic acidosis. Very, very common. They can cause a severe high ion gap metabolic acidosis, which is heavily possible. Most of them, this is due to the lactic acidosis due to tissue hypoxia, because they cannot use the Krebs cycle. They have to go with glycolysis and they have to go for anaerobic metabolism because mitochondria is shut down. That's why. So this is also possible. And finally, going for the treatment. Treatment is you have to first decontaminate, because I told you it can be absorbed through skin also. So you have to remove the clots, wash the skin. Decontamination is very important. Number 2, give 100% oxygen. And regardless of the saturation, this is very important. Even if they fool you by telling the saturation is 100% and the patient is having a suspected cyanide poisoning, you have to give 100% oxygen, regardless of saturation findings. What you get, it's not the key, because you have to somehow, you have to get the Krebs cycle going on, ATC going on. So you have to give 100% oxygen. At least the competition, you have to somehow force the ATC happen. So it's very important. At the same time, you have a lot of antidotes that you give. If they ask you the choice of antidote, the first choice antidote is something called hydroxycobalamin. Hydroxycobalamin. So it is a precursor of vitamin B12. You know that methylcobalamin. This is hydroxycobalamin. This combines with cyanide. So this is going to combine with your favorite cyanide, and that is going to form something called cyanocobalamin after mixing with cyanide. And this cyanocobalamin can be rapidly excreted in the urine, without a doubt. Can be completely rapidly excreted in the urine very fast. So which means we are making a non-toxic and quickly excretable form of cyanide. So that's the idea. So number one, I'm the hydroxycobalamin. Second thing, if this is the choice, if you ask me the treatment of choice, or I don't like personally the TOC forms, but still, so if you ask me the choice treatment, then it will be hydroxycobalamin. If this is not available, if your treatment of choice is not available, that hydroxycobalamin is not available, there are other alternatives are there. Alternative treatments, you have something called sodium nitrite, or you can use amyl nitrite, sodium nitrite or amyl nitrite. So why this is important, the sodium nitrite, amyl nitrite? Because this increases the production of methemoglobin. I already told in the last video, one of the important sources of methemoglobin is the nitrite, to be honest. So they are going to increase methemoglobin. So why methemoglobin is very important? Because Fe3 plus is going to have high affinity for cyanide. Fe3 plus is going to have high affinity for cyanide. For example, why it binds with your cytochrome complex number 4 is the reason is because it's heme. Fe3 plus is there in the cytochrome 4 complex also. That's why it binds. The heme is the reason why it binds with the cyanide binds with the cytochrome 4 complex. Actually, what we are trying to do is by making this Fe3 plus in the hemoglobin itself. So you have ETC heme, which is having Fe3 plus, and you are having hemoglobin itself in the form of Fe3 plus, which means you are diverting this cyanide from binding with the cytochrome complex towards your methemoglobin. So which means you are going to form cyanhemoglobin. So that is the idea. The cyanhemoglobin again can be excreted, like in many different ways your cyanhemoglobin can be excreted. So your idea is to create a non-toxic cyanhemoglobin which can be converted to, which can be degraded by sodium, rhodinase enzyme, which I'll discuss in the next step. So this is what you're going. So you are essentially diverting the cyanide to bind with hemoglobin rather than binding with your ETC, and you make the cells breathe. That's the idea. So that's how you give the sodium nitrate or amyl nitrate. You are artificially inducing methemoglobinia here. That's it. So number 3, third one, what you can use, it's an alternative. That is what we call the sodium thiosulfate. Why you give sodium thiosulfate is because you have an enzyme in the mitochondria called rhodinase. You have an enzyme in the mitochondria called, it's a mitochondrial enzyme. So you have rhodinase enzyme. Rhodinase, what it does is it converts cyanide and related compounds, cyanide plus related compounds, and it converts that to thiocyanate. It uses sodium thiosulfate and it converts to thiocyanate. So for this enzyme to work, your sulfur groups are very important. Which can activate the rhodinase enzyme. So these sulfur groups are provided by your thiosulfate, sodium thiosulfate. So which means the sodium thiosulfate indirectly is going to activate the rhodinase enzyme. So once it activates, they're going to convert the cyanide and related compounds into thiocyanate. This thiocyanate can be excreted in the urine much faster. At the same time, this thiocyanate is relatively a non-toxic compound which can be excreted in the urine faster and faster. You can eliminate the cyanide. So for that matter, the cyanhemoglobin also travels the same pathway. Cyanhemoglobin can be converted to thiocyanate and it can be excreted in the urine. Hemoglobin will be left free, only the cyanide part will be excreted. So all these things forms a very important strategical treatments. The best is hydroxycobalamin. If it's not available, you can go for sodium nitrate. If that is also not available, sodium nitrate or amyl nitrate is also not available, then you can go for sodium thiosulfate. But remember, a patient is having a congenital methemoglobinemia, you cannot give sodium nitrate or amyl nitrate because the patient is having G6P deficiency. I'm not going to induce more and more methemoglobin in these patients. So in those patients, you can prefer sodium thiosulfate. Remember, but sodium thiosulfate is not that good. Usually, it is given as an adjunct to hydroxycobalamin. It can be given as an adjunct to hydroxycobalamin. That's why we use sodium thiosulfate in real time. But it may be used when these things are not available. The first line, two line treatments are not available, or if it is contraindicated. But there is no contraindication for a hydroxycobalamin. But your sodium nitrate may have contraindication. In methemoglobinic cases, still a contraindication. But your hydroxycobalamin has no contraindication. You can use in any suspected cyanide poisoning. So now I can tell you the final chart where what will be the oxygen content of the arterial blood. CaO2 stands for content of oxygen, and we have something called SaO2, that is called saturation of arterial oxygen, and what will have is your PaO2, that is your partial pressure of arterial oxygen. At the same time, finally you have ODC, oxygen hemoglobin dissociation curve. So first, what happens in anemia? In anemia, the content will be reduced because content of oxygen in the artery, C for content, A for artery, of oxygen decrease because the hemoglobin itself is decreased, saturation is normal, PaO2 is normal, ODC is not shifted because anemia is not known to cause any shift in the oxygen hemoglobin dissociation curve. Then you have polycythemia. So in this condition, your oxygen content may be increased, but if it's the patient is a smoker, it might be normal. Because the relative excess of other types of hemoglobin, dysfunctional hemoglobin. So, but anyway, polycythemia in general will increase the content of oxygen. But if it's a smoker or there are other dyshemoglobins present, it might be even normal or decreased, which we have discussed already. The saturation is normal, PaO2 normal, ODC normal, doesn't get shifted in hemoglobin changes. And if you have a dyshemoglobin, typically you have a carboxyhemoglobin or a methemoglobin. Carboxyhemoglobin or methemoglobin, the content is decreased definitely, and your saturation SaO2 will be decreased, there is no doubt about that, and the PaO2 will be normal because this doesn't affect the PaO2, dissolved oxygen, I already told you, and the ODC will be shifted towards the left. ODC will be shifted towards the left, and also remember SpO2 will be variable in methemoglobin and carboxyhemoglobin. SpO2 in methemoglobin will be 85% falsely decreased, in carboxyhemoglobin it can be even 100% falsely increased or normal. So finally you have something called cyanide poisoning. In cyanide poisoning, content will be normal, SpO2 will be normal, PaO2 will be normal, and there is no ODC shift. Oxygen hemoglobin dissociation curve will be normal. Everything is normal. The patient will exhibit only acidosis, that is due to tissue hypoxia, cellular level problem. And finally, if you have high altitude exposure, the patient is going to have content will be reduced because of the low oxygen PaO2 itself. The PaO2 itself will be reduced, but the saturation will be normal. At the same time, your ODC will be right shifted in high altitude, which we have discussed already. That is going to, this is a very important table and many times tested in exams. In this particular, if they wanted to ask this particular question, with this I think we have covered enough on the pulse oximeter and dyshemoglobin part. And in the subsequent videos, we are going to see on the classification of the anemias, definition of anemias, and probably maybe iron metabolism in subsequent videos.